சார் சொல்லுங்க சார்.
ஒரே இன்ஸ்டிடியூஷன் தானே சார் அவங்க 3 பேரும்?
ஆமா, எப்பயுமே ஒரே இன்ஸ்டிடியூஷன் தானே.
எந்த இது சார்? எந்த இது அவங்க?
இது மேத்தா சில்ட்ரன்ஸ் ஹாஸ்பிடலுங்க.
மேத்தா இருந்து.
ஆமா. Next,
Kumaresan sir is just finding it a little difficult to join. Adha or 1-2 minutes la he'll join sir.
Okay. Actually join பண்ணாரு மடியும் டிஸ்கனெக்ட்.
ஆமா சார், அதே போன்ல இருந்து ஜாயின் பண்ணிருக்காரு. So இப்ப லேப்டாப்ல இருந்து பண்றேன்னு just he asked for 2 minutes.
Hi Shivan.
Hi sir. Sir, thank you for accepting at the last moment sir. Thank you.
Yeah, I did one last week also with in Trichy. So
அதுதான் சார், I saw that flyer. So I thought திரும்ப இந்த வாரம் எப்படி கூப்பிடுறதுன்னு யோசிச்சுட்டு இருந்தேன் சார். பட் நாங்க சங்கீதா மேடமோட பேசிட்டு இருந்தேன். மேம் சொன்னாங்க ரஞ்சித் சார் கூப்பிடுங்க, கட்டாயம் வருவாரு, முடியாதுன்னு சொல்ல மாட்டாரு அப்படின்னாங்க. சரி.
So weekends are free only, so we still keep engaged.
Yeah.
கோமதி, ஸ்வாதி, வெல்கம். இன்னொருத்தர் யாரு? சஃபா
சார்.
Okay. குமரேசன் சார் பார்த்து ரொம்ப நாள் ஆச்சு. ஐ திங்க் இஸ் லெஜெண்ட். ஐ திங்க்
Srinivasan sir has joined from Mangalore sir. He has gone for a PG clinics in Mangalore.
Sir, welcome sir.
Good evening sir. Good evening sir. Sir, mute la irkeenga sir.
Sir, mute sir. Unmute பண்ணுங்க sir.
Good evening. Just I came to my room. I will put on my shirt and this thing 1 minute.
Yes. வணக்கம் சார். வணக்கம் சார். Srinivasan சார் வணக்கம்.
வணக்கம் ஐயா சிவன்.
வணக்கம் சார். சார்
Before I come to the specific thing.
Just 1 second, I'll just call sir and ask if he's having a problem.
Trust across the tribal belts. Besides, what is always there in the chamber. One tribal belt.
ட்ரெஸரர் காணாங்க மித்ரு.
think she may not join நினைக்கிறேன் சார். ஏன்னா அவங்க டிராவல்ல இருக்காங்களா என்னன்னு தெரியல சார்.
ஓகே.
I cannot start my video because the host has stopped it.
Hello. Try பண்ணுங்க சார்.
Murugan, it is written host has asked you to start my video again. Okay, let me see. It has come. Thank you.
Actually, நீ ஜாயின் பண்ணிருக்காங்களா சார்?
ஜாயின் பண்ணிட்டாங்க சார். ஜாயின் பண்ணிட்டாங்க.
வணக்கம் சார். வணக்கம் சார். பேராசிரியர் அவர்களுக்கு வணக்கம்.
Sir, good evening sir.
திருமுகத்தை காமிங்க.
எத்தனை தர மாட்டேங்கிறாங்க.
நீங்க வரலன்னு ஒண்ணே புரோகிராமே ஆரம்பிக்க மாட்டேன்னு சொல்றாரு.
மர்மம் என்ன?
அகாடமி கோஆர்டினேட்டர்.
மறைந்திருந்து பார்க்கும் மர்மம் என்ன?
சார் நீங்க அழகாவே பாடலாம் சார். நீங்க ஏன் சார் அவசரமா பாடுறீங்க? நீங்க அழகாவே பாடுங்க சார். கேட்கறதுக்கு தயாரா இருக்கு சார்.
தாக்ஷாயணி அந்த இதுக்கப்புறம் நேர்ல வரமாட்டேங்கிறாங்க.
எதுக்கப்புறம் சார்?
அதான் கோயில்லாம் போயிட்டு வந்தோமே. வேளாங்கண்ணி போயிட்டு அந்த சிஎம்இ ப்ரோக்ராம்
வேதாரண்யம். எஸ் சார்.
எல்லா சிவன் கோயில்கள் எல்லாம் அப்புறம்
சார் நம்ம ஆரம்பிச்சிடலாம் சார்.
ஆரம்பிச்சிடலாம்.
எல்லா பிரமுகர்களும் வந்தாச்சு, எல்லா ஸ்டூடெண்ட்ஸும் வந்தாச்சு.
குமரேசன் சார் வரலன்னு நினைக்கிறேன்.
இல்ல சார், அவருக்கு ஏதோ லேப்டாப்ல கனெக்ட் பண்ண ட்ரை பண்ணிட்டு இருக்காரு சார். இந்த மீன் டைம்
ஸ்டார்ட் பண்ணுங்க சார்.
ரைட் 87 ஆயிடுச்சுல ஸ்டார்ட் பண்ணுங்க.
ஆமாங்க சார். So good evening everyone. Welcome back to our series of postgraduate clinics. Today we are having our 89th session, which has been going on for the last 3 years, almost every weekend. Now of course now we are doing it every other week. Let me start today's program by requesting our Treasurer Dr. Dakshani to say the pediatrician prayer, please.
குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கோம், மாற்ற முடியாதனவற்றை காரணத்தோடு ஏற்றுக்கொள்ளோம். போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ சார்.
Thank you, Dr. Dakshani. It's again a great pleasure to have the eminent panelists starting with and our judges starting with my teacher Professor Srinivasan sir, our academy, our president Suresh Balan sir, who has been very enthusiastic about these programs, our academic coordinator. May now request our president to say a few words before I can hand over to our academic coordinator.
Thank you, Dynamic Secretary Dr. Thirumurugan. Very good evening to one and all. So very happy occasion once again under the able leadership of our academic coordinator, Professor Rajendran sir. This is one of the pet projects of IAP TNSC. We are conducting this program online for past few years. So today we have got a very important topic to be discussed. And we have our judges, Professor Srinivasan sir, who has joined online, and our chairperson, the stalwart of this program, Professor Kumaresan sir, a legendary neurologist, a pediatric neurologist, a teacher of teachers. We are very happy, we are very fortunate to have him with us this evening, in spite of his very busy schedule. And we have got eminent moderators, Professor Dr. Ranjit Kumar, who has joined all the way from Toronto. So very happy occasion.
Ranjit Kumar and Professor
Shivan Kesavan. And Professor Ranjit Kumar has spared his valuable time, even though he's abroad, who's been concentrating on pediatric epilepsy. Very nice to have him, sir. Also the learners for today's program, Aisha, Gomadi and Swati. On the topic of child with the loss of milestones, a very important topic. And I was also very happy to send this same flyer to my postgraduates at Kanyakumari Government Medical College. They were very fortunate to join online today. So this is one of the very important programs which is very useful, in fact, for all the postgraduates from various institutions who can join online as well as view through our YouTube channel. So thank you, Dr. Rajendra sir, for taking all efforts, sincere and dedicated efforts, persistent efforts over the years to make this as a successful one. Thank you very much to our dynamic treasurer, Dr. Dakshani, and all the office bearers, EB members. Thank you very much.
Thank you, sir. May now hand over the session to our academic coordinator, Dr. K. Rajendran, for conducting the session, please.
Yeah, thank you, Dr. Thirumurugan, our honorary secretary, respected our president, dynamic president, Dr. Suresh Balan, and dynamic secretary, Dr. Thirumurugan, and treasurer, Dr. Dakshani. And today's postgraduates from Mehta Children's Hospital. And I really welcome judges, Dr. Ramesh, and as well as Dr. Ramachandra Mohan, Dr. Srinivasan sir from Pondicherry. And I welcome today's chairperson, Dr. none other than our legend of neurology, pediatric neurology, Dr. Kumaresan sir. And I welcome our today's moderator, Dr. Shivan Kesavan. He took a lot of interest to organize this program today. And I welcome Dr. Sivan Kasaman, and I welcome Dr. Ranjit Kumar, who is currently in Toronto, who is doing pediatric epilepsy. And I welcome Dr. Ranjit. I welcome all the postgraduate students from Sabha, and as well as Dr. Pamadi and Swati Magan from Mehta Children's Hospital. I welcome all the learned faculties as well as students all over India who has joined here. On behalf of IAP TNC, I welcome one and all. Now I hand over to Dr. Sivan Kasavan, because Dr. Professor Kumaresan sir is actually now yet to join. And please take over the proceeding, Dr. Sivan Kasavan, please.
Thank you, sir. Thank you. Thanks to everyone for making this event happen. It's been a very useful session for all postgraduates. I'd like to offer my greetings to all the teachers, including Professor GK sir and Professor Srinivasan sir and all of the office bearers. I'd like to appreciate Swati, Safa and Gomati for taking up this case. So you can start presenting, Safa. We'll start discussion of this case. This discussion is planned for 1.5 hours. And Ranjit sir has offered to give a short overview of the approach to neurodegenerative disorders and neuroregression, along with some ASCIIs at the end of the session. So we plan to end the session by somewhere around 1 hour and 15 minutes, along with the discussion. So I think Safa can start.
Yes. Good evening, everyone. Myself, Dr. Safa, and Gomati and Swati from Mehta Hospital. This is a 8-year-old girl child, first born to a 3rd-degree consanguineous parents, hailing from Tanjavur, whose informant is mother with a good reliability. Presenting complaints: progressive difficulty in walking associated with abnormal twisting movements involving the limbs, noticed since 4 years of age. History of presenting illness: child has pre-existing speech delay with normal motor milestones till 4 years of age. This speech delay will be dealt in detail in the developmental history. At 4 years of age, mother noticed child walking on toes, which was insidious in onset and gradually progressing with frequent falls due to twisting of legs. After a period of 6 months, child was not able to stand and walk without support. And at the age of 6 years, child developed abnormal twisting movements of both the upper limb, leading to bizarre posture and gradually progressing to involve the neck in the form of intermittent arching, aggravated by emotional stress, spontaneous movements, and disappears in sleep. Hence, the child was not able to hold the glass of water, not able to feed by self. There is no history of sequential involvement of the limbs of the dystonic movements or diurnal variation in the dystonic movements. History of poor clarity of the speech noted since 6.5 years of age, associated with the abnormal thrusting movement of the jaw, tongue, which was gradually progressive. Now the child does not have any intelligible speech. No history of seizure or epileptic spasm or myoclonus. Child is able to recognize the parents, strangers, and obey simple commands, has no excessive irritability, able to convey the inner needs, able to convey wet inner garments, and convey desire to pass stools, and able to sleep well. No history of abnormal behavior in the form of aggression, self-injuries, or emotional disturbances. Child is able to lift the upper limb and reach for objects above the head, has difficulty in holding the pen, able to lift the neck above head, turn side to side, raise the leg off the bed, but all these movements are accompanied by the involuntary movements. Mother does not have any concerns related to vision, no history of squinting of eyes, able to chew the food well, sleeps with both eyes closed, able to turn to sounds, able to swallow food without choking or regurgitation, able to turn the head side to side. Child can be able to appreciate the differentiation between hot and cold while eating, bathing, grimace or painful stimulus. No history of bladder or bowel incontinence. No history of loose stools, constipation, excessive sweating or recurrent fever or hypothermia or skin color changes. No history of post-neonatal jaundice, polyuria, polydipsia, abdominal distension. No history of exaggerated startle. No history of episodic worsening or episodes of acute encephalopathy.
Can we pause here and have a discussion on the presenting complaints?
Yes, sir.
So can you go to the first slide? I'd request Ranjit sir to drive the discussion. Sir, you can start, sir.
So yeah, thanks IAP and thanks Dr. Shivan Kesavan for inviting. Is JK sir here? I think he has not joined, right? Like it's fine.
Sir, he's having a problem in joining, sir.
Okay.
So,
Okay. So so far nice presentation. May I know the name of the presenter? Sorry, I did not get that. Dr.
Sir,
Person.
she's Dr. Safa. Safa is the presenter.
Okay, so Dr. Safa. So it's nice presentation so far. So I just want to know, like if you go back to the complaints, like I would have split this into two separate presenting complaints instead of combining this two as one problem, because like you need to convey to the examiner the key messages, like, you know, the attention span is so limited. So I would say, like, I would split them into two different complaints, like progressive difficulty in walking, definite, okay. And there is an abnormal twisting involving all the four limbs, I think. You said all the four limbs, am I correct?
Sir, first initially started with the lower limb, sir. Then
So now it's all the four limbs. So that's one thing I want to convey. Go to the next slide. So he has pre-existing speech delay. So I guess he had speech regression. Am I correct? You said now he's not able to speak.
Now he has no intelligible. She has no intelligible speeches. She is able to speak well now, but not up to now 8 years of age. But to the 8 years, the speech is not normal. But she is speaking whatever we are asking. She is responding to that.
Okay.
But the
So let's go by one by one. So yeah, okay, good. So let's go by one, step by step. So you said 4 years of age, started walking on toes, and then he has like onset good, gradual progression good. So we would like to hear, is there any precipitating factor? That's very important. So whenever we discuss about regression, is it a spontaneous onset? Insidious is different from spontaneous, right? So we need to hear, is there any precipitating factor in the form of a illness like a fever or a trauma or any other insult? That's
there
one
was
thing.
no precipitating factors, sir.
Yeah,
no fever, no trauma, nothing.
Yes. So it's a spontaneous insidious onset. That's what I want to hear. The next is frequent falls due to twisting of legs. Yes, you said that. But it's good, like we would like to differentiate other causes of falls also. That's usually we discuss in pediatric neurology. You need to bring it out. What is the exact cause of fall? I get a sense it's most likely a dystonia. I agree, but we need to rule out the other causes. So maybe the other students here, like what are the common causes of falls while walking? We don't have much time, so yeah.
Yeah, quick answers, Gomati or Swati, quick answers.
The frequent falls would be due to any muscle involvement, or muscular dystrophies, or any weakness.
So one, it can be due to muscle weakness, is what you mean to say. Weakness can be a source of falls, yes. So weakness can be due to the muscle, the neuromuscular junction, or the nerve. Agreed. Next.
Any orthopedic problems, bone disorders.
Okay, so musculoskeletal problems.
Musculoskeletal.
So, okay, right. That is point number 2. Next. Anything else?
That's good. Yeah. Vision abnormality.
Yeah.
And what about seizures? Like, you know, there are myoclonic, atonic, there are some seizures. So you need to ask one question just quickly at that stage, just to differentiate it's only a dystonia. Like I would like to add, there is no history of buggling or no history of loss of consciousness, no history of jerking or loss of tone preceding this falls, just to quickly give an impression. Okay, then after a period of 6 months, the child was not able to stand and walk without support. Okay, so that's a regression of motor milestones. Go to the next slide. Then he started developing abnormal twisting postures, leading to bizarre postures in the form of intermittent arching. So you rightly pointed out, we are trying to deal with a movement disorder. because you said it is aggravated by stress, spontaneous movement, and disappears during sleep. That's good. And there is no history of diurnal variation. So why did you ask about diurnal variation? Is that important pointer here, or what is the significance of that? Yes, some forms of primary dystonias can have diurnal variation. That's good. So yeah, so when we ask about this movement disorder, at that stage itself, I would like to rule out other movement disorders, right? Like he has dystonia for sure, but usually movement disorders are generally mixed, right? So what are the other things you would like to rule out at that stage?
Chorea movements,
Yeah.
movements.
So just quickly add on, there is no history of, like, you can put your words like violent flicking movements or dancing movements or jerking movements. Yes. And also I want to hear, so now it started 6 years age. Is this dystonic movement or dystonia is also progressive? You said in terms of extent. I would like to hear in terms of severity.
It is also progressing, sir. Initially, it was mild intensity, and now it has been aggravated. The intensity has increased. The involuntary movements are also affecting the functional activity of the child.
Okay, so you clearly described about the extent, starting from limbs and going to the whole body in the neck also. We would also like to hear the severity. Is it progressing in terms of severity? Okay, and clarity of speech. So I want to bring it out, like, so before we start about regression of speech, you need to give what was his best speech before he started regressing. Is this speech regression? I just want to bring it out. Is this speech regression?
It was no speech regression, sir. The speech is static. There is a delay beginning to the involuntary movements. There is a delay in the speech. Even at 4 years of age, the child was talking only bisyllables, sir. So the speech is delayed and has not picked up also. It is constantly static. And now it is able
to... So Safa, what you need to clarify is that you say that there is a speech delay and there is some worsening in speech also after a certain point in time, right? Yeah, so you mean to say that because of a non-central problem, the child is having unintelligible speech this time.
Can
right?
I ask clarification, Dr. Shivan Keshavan and Ranjit?
Yes,
sir.
Yeah, I just wanted to know, she has mentioned about hence the child was not able to hold the glass. Okay. So I want to know whether there was any spillage while taking near the mouth. So was there any shaky movement and she was spilling this thing that will give us a little more clarity about whether it is cerebellar or extrapyramidal.
So was there any history like that, Safa?
Sir, child was not able to even hold it. It could not bring it near the mouth itself. Even by holding itself, there was spillage. So it was not able to, even before 4 years, it was feeding by self. And after this involuntary movement started, it could not even hold anything. So spillage was there. Even if it was given a glass of water, there was spillage of water.
So basically, there are 2 points here. So one point is what Dr. Ranjit sir had already told. See, severity you can assess by this. The child was initially able to, feed by herself, was able to walk a certain number of steps, was able to, the number of falls were less. Probably with time, the disease has progressed. Because of that, the child is not able to walk without falls, not able to walk without, a parental assistance, and not able to feed herself successfully, right? So this is again a marker of severity. What Professor Srinivasan sir wants to clarify is, was there an added component of cerebellar dysfunction as well? So how would you ask in such child, in the history only, not going into examination, that is there cerebellar involvement or just, extrapyramidal problems?
Sir, any abnormal eye movements we lost, and the gait was abnormal, but it was swaying or ataxic gait will be there, and tremors.
Yeah, so tremors, yes, it is a sign of cerebellar involvement, but can you have tremors in a child with dystonia without having cerebellar involvement?
It is also a part of involuntary movements.
Yes, yes. Yeah, so we call it dystonic tremors. In a child with severe dystonia, tremors can be superadded. So these are called dystonic tremors. They can be present. So it does not, just presence of tremors does not mean that the child has cerebellar involvement, but an intentional exacerbation definitely means that there is a cerebellar involvement. So when the child approaches the target, if the child has more tremors and not able to accomplish the task, then it means that there is cerebellar involvement as well, among the other signs you had mentioned. Okay. Yes. Yeah. So,
yeah. So, hi, Dr. Shivan. I still want to have a clarity on speech. So, did he have meaningful words to begin with, or was he averbal? Just I wanted to confirm that.
Safa, you can go to the slide on speech development. You had written pre and post illness. So,
okay. So then we can discuss at that time. I think if you are going to discuss on that. Okay, go to the next slide. Okay. So you asked about history of seizures, epileptic spasms, and myoclonus. So just wanted to tell you, epileptic spasms is usually 1 to 2 years of age, right? Less than 2 years of age. So like you can bring it more like need not be very specific. Any specific reason why you specifically ask about epileptic spasms? Because it just stands out. Yeah. Anyway, we are dealing with 8-year-old. Okay. Next slide. Yeah. So he's able to recognize. That's good. Okay. No. Yeah. Okay. Okay. Good. So So nicely you brought out the current functional status of the child. That's very important. So when we talk about regression, the onset, the progression, the nadir, and the current function. Yeah. Good. Next slide, please.
Okay. Okay. Nobody now. I am in some other place. I don't know who are on duty. You go to casualty and tell my name. Dr. Srinivasan, Professor Srinivasan.
yeah,
okay, I think we can go with the negative history. Yeah. Go on. Yeah.
No history of post-neonatal jaundice, polyuria, polydipsia, or abdominal distension. No history of exaggerated startle. No history of episodic worsening or episodes of acute encephalopathy. No history of abnormal head growth or restriction of eye movements. No history of abnormal urine or sweat odor. No history of skin or hair changes. No history of visual disturbances, including difficulty seeing in the dark or bumping into objects. No history of drug intake or loss of weight or chronic diarrhea. No history of constipation or regurgitation of food or drooling or reflux. No history of recurrent respiratory tract infection, pain in the limbs, non-healing ulcer. No history of intractable vomiting, headache, or double vision. No history of easy fatigability or exertional dyspnea.
Okay. Just go back, like for other students here, like, can you just quickly say, why did you ask about polyuria, polydipsia? Let's go on by one.
For each she should give an explanation.
Yeah,
exactly. What was the reason? Each you have to justify. That's how examiners ask you. I asked.
Yeah. So can you quickly go through the whole thing and say, why did you ask for that? Yeah.
Sir, post-neonatal jaundice, polyuria, polydipsia, and abdominal distension for Wilson's disease, sir. And exaggerated startle for Tay-Sachs and Krabbe disease, sir. And episodic worsening or episodes of acute encephalopathy for mitochondrial disorder because and organic acidemia with a recurrent fever, intercurrent illness, they will worsen. No history of abnormal head growth or restriction of eye movements. Abnormal head growth for macrocephaly and microcephaly, and restriction of eye movements, upward gaze palsy in Gaucher's and Niemann-Pick disease, vertical gaze palsy, and abnormal urine or sweat odors for organic acidemias, and skin or hair changes for biotinase deficiency, Menkes disease, skin changes for biotinase deficiency, phenylketonuria, visual disturbances including difficult seeing in the dark for NCL, no history of drug intake for pseudo-regression, and loss of weight and chronic diarrhea for HIV, constipation, regurgitation of food, drooling, and reflex, a complication of a neurological disease involving the GIT, and recurrent respiratory tract infection for respiratory, and pain in the limbs in the contractures, non-healing ulcers for bed sores, and intractable vomiting, headache, double vision for raised ICT, and easy fatigability or exertional dyspnea for cardiac involvement.
Okay, Safa, you had mentioned a name of a disorder for visual disturbances. Apart from that, which other disorder would you think of in a child with generalized progressive dystonia with presenting with visual disturbances or night blindness? Yeah. So that again becomes significant in this child, right? And then you had mentioned about intractable vomiting, headache, double vision. So this is for raised ICP. So what do you mean by raised ICP? Why would you think of that in this condition? This present. You're not audible. So you want to rule out a space occupying lesion is what you mean, right? Right. Okay. So you wouldn't think of such kind of a lesion in a child with such a prolonged history. The child has been having this problem for nearly more than 4 years. Okay. So, but still in a child with, neuroregressive symptoms with probably a unilateral onset, you will always look for focal signs and raised pressure signs because you want to rule out a space occupying lesion like a tumor, which is going to cause such kind of a regressive presentation. So that is probably what you meant, right?
Yes, sir.
Right.
The current functional status of the child. Currently, child is able to hold the neck steadily, sit without support, stands and walk with support, able to chew and swallow the food fed by mother, understand and obey simple commands by mother, dependent on mother for toilet needs. Treatment history at 4.5 years of age, mother consulted.
Just hold on for a second. So in your framework, so far very nicely you have done. So you talked about the presenting complaints, you elaborated them, you did talk about a lot of etiological negative history. There is one part which I feel should be straddling between these two, that is neuroaxis. So maybe Dr. Shivan Keswan, Dr. Srinivasan. So can you just briefly go to that? Like, do you have a separate discussion
Sir,
of that?
this is first one is higher mental function. To assess higher mental function, able to recognize parents, teachers, obey simple commands, able to convey the inner needs. And for personality changes, abnormal behavior in the form of aggression and self-injuries and emotional disturbances. And this is for motor system, upper limb for proximal and distal muscles, and lower limb and neck muscle lift the neck above the head and turn trunk muscles, turn side to side and raise the leg off the bed is for the proximal lower limb. But all these movements had accompanied involuntary movement. And cranial nerves, mothers have no vision or near.
So what about the tone, the resting tone? Like we are still in history, I agree.
Yeah.
So any comment? So do we hear about resting tone?
Sir, tone, when I examined the child, the tone of the was...
No, in the history. Like how would you ask about, we are still in the history. What would you ask the parent to understand what could be the resting tone in an 8-year-old child?
I think you have to come closer to the mic and talk, all three of you.
Sir, stiffness or flaidness of was not told by the mother, sir.
Yes. So even if the child is having dystonic movements, when in periods of quiescence, you can ask how are the limbs, are they stiff? And if it is spasticity, even during sleep, although it reduces and decreases significantly, you would still have some degree of stiffness, right? So you need to bring that out like as a tone. Go to the next slide. Yeah. So we are just going to the extra mile, like just not being critical here, just being going to ask the finer points. The next one, because you need to understand extrapyramidal syndrome. Is it dystonia alone or plus tonal involvement, stiffness? Is it spasticity or rigidity? Just moving towards that direction. Okay, next slide.
Dr. Ranjit, can I interfere for a minute? Is there a change in the tone during sleep? All extrapyramidal disorders should you mention about what are the changes in sleep? Would you agree?
Definitely, sir. So, like in an extrapyramidal syndrome, we expect rigidity. So, rigidity should absolutely should be off during sleep. If it is spasticity, which is due to pyramidal involvement, will persist, but it will be significantly less during sleep, but it is still there. And
Okay.
all movement disorders, except for maybe sleep myoclonus, cease during sleep.
Great, sir. Thank you. And Safa, what sir had mentioned and we had actually missed here is the mention about the other movement disorders. So one statement about chorea, athetosis, the presence of tremors and all that should be mentioned. So just because a child has a single presenting movement disorder doesn't mean that he shouldn't have the others, right?
Okay, sir.
So while you are talking about dystonia itself, you can convey as in one line that we as an examiner know that you know what to ask for. That's what we are looking for, right? Okay. Next slide. Next slide, please. Yeah.
So this is for cranial nerves, vision and hearing, squinting of eyes for 3, 4, 6 nerves, and able to chew the food well for 5th nerve, and sleeps with both eyes closed for 7th nerve, able to turn to sounds for 8th nerve, swallow the food without choking for 9 and 10 nerves, and able to turn head side to side for 11th nerve.
Right. So rest of sensations and bowel bladder you had covered. So what is the last statement? Can you explain why you had mentioned loose stools, constipation, sweating?
So loose stool, constipation, excessive sweating, fever, hypothermia for autonomic disturbances. This will be there in amino acid carboxylase deficiency. They may be present with the autonomic disturbances, sir.
Okay, so for neurotransmitter deficiency disorders, presence of autonomic dysfunction signs are important in diagnosis. Okay, so we'll discuss why these are less likely and all later on, but this is why you had mentioned this. Okay, you can move on. So this is the functional status of the child, and you're going to the treatment history, right?
Yes, sir. Sir, at 4.5 years of age, the mother consulted nearby hospital for toe walking. The child was treated with a plaster of Paris for a month. The symptoms persisted, but the child was lost to follow-up due to COVID. Then by 6 years of age, child was admitted and evaluated for abnormal involuntary movement in tertiary hospital and treated with the oral medication. Now the child got admitted for worsening involuntary movements and increased difficulty in walking. Moving on to developmental history, pre-illness gross motor, child attained the neck holding by 3 months, rollover by 5 months, sits with support by 6 months, without support by 8 months, stands with support by 10 months, walks with support by 1 year, walks without support by 1.5 years, climbs stairs with 2 feet per step by 2 years, with 1 feet per step by 3 years. But post-illness, child is now sit without support, walks and stands with support. Developmental age is around 12 months, and quotient is developmental quotient is 12%. Fine motor.
So Safa, what do you make of the motor state right now? Has it undergone regression?
Yes, sir. Child was able to walk independently.
There is significant
regression is there
in the gross motor sector. And what about fine motor?
Fine motor also, it was able to copy circle by 3 years. Now it has only immature pincer grasp, sir. There is a developmental age is around 9 months, and the developmental quotient is 11% only.
Right. So there is gross and fine motor regression, probably due to these involuntary movements associated, right?
Yes, sir.
Okay. So go to the next sector.
Language, the child has attained monosyllables by 18 months and bisyllables by 2 years, and speaks 2 words by 4 years, sir. Post-illness, now the child able to speak 5 to 7 years with poor clarity, and developmental age is 18 months, and developmental quotient is 20%.
Okay. So what do you think the developmental quotient of the child pre-illness would have been? So basically, when you talk of regression, you have to compare the change in developmental quotient between two time points, right? So that is how you identify regression on a theoretical point, right?
Yes,
so, yeah. So pre-illness itself, the child had significant speech delay. Right? And post-illness, the child had. Did the child lose any of the language milestones the child had gained by that age, by 4 years?
No, sir. It has not. It has not lost the language milestone, sir. It was delayed.
Yeah. So the developmental age at 4 years before the onset of these symptoms for which the child is presented was also corresponding to somewhere around 2 years. Yeah. And now as well, the child's developmental age is nearly at the same age, right? 18 to 24 months is what you mean to say.
Yes, sir.
Right. But the child's speech was intelligible. That is, the parents were able to make out most of what the child,
Yes, sir.
uttered. By 4 years of age, now the child is not able to do. By 4 years of age, the parents should be able to understand how much percent of the child's speech. What is a normal milestone at that age?
Precise,
most of-
ask questions.
Yeah. So most of what the child says, the parents should understand. So intelligible speech should be nearly, somewhere around 100% by age of 4 to 5 years. Right now, the parents are not able to understand what the child says. So this is probably due to what?
Sir, oromandibular movements.
Okay. So this is not, this is not due to language regression. This is probably due to the dysarthria the child has due to extrapyramidal involvement. This is our hypothesis at this time point, but we'll have to do examination to find that out, right? We need to test the child before concluding this. Okay, move ahead.
Social and adaptive, pre-illness recognized mother by 4 months, bye-bye by 1 year, played simple ball game by 2 years, dry by night by 3 years, knows name and gender by 3 years. Now the child is able to say name, get excited on seeing toys, show affection for younger sibling. Developmental age corresponds to 3 years. Developmental quotient is 37%.
Okay, so ideally for pre and post illness, you should mention developmental quotient. Only then we will be able to understand which sector has regressed the most, right? Mentioning one developmental quotient at this time point will not make much sense. Okay, so that is one thing which you will have to correct in the next presentation. Okay, so if you feel that the social development has regressed, which had started around 2-3 years of age, what would you consider in this child? What is the clinical syndrome you may think of? When you feel that the child with speech delay starts regressing socially around 2 to 3 years of age, what do you think of? Yes?
Rett syndrome.
Rett syndrome, yes. But Rett syndrome's regression starts a little earlier, right? Rett syndrome's regression starts very early, right? Much earlier than the usual autistic regression which we see. So the most common problem these days is autism spectrum disorder. So you should know what autistic regression is about. Probably in this child it may not be significant, but you should know what autistic regression means and what, Rett's associated regression, how does it take place. So in this, it is a girl child, and if there is a history of early regression, speech regression around 1.5 years of age with social skill regression and dystonia presenting at this time, would you still consider Rett syndrome? Yeah, it is also possible, right? Yeah, Rett syndrome is another disorder which can present with extrapyramidal movements. Okay, we'll discuss all that when we discuss the differentials, but this is just to give a perspective. So at the end of this, probably you've discussed all developmental sectors.
Yes, sir.
Yeah, so at the end of this, what do you make out at the end of development?
So it's a regression of the motor, gross motor and fine motor milestones, sir. And language is, there is a pre-existing, pre-illness also, there was a delay, and now also for the 8 years, the child has not picked up the language. And social and adaptive also remains static, sir.
Yeah, but the child has not regressed.
Regressed in the social
language sector.
Language, yeah.
Right, okay, right. So currently this is the developmental status, right?
Yes, sir.
Right, this you have mentioned already in the functional status. So probably we'll move to the next slide.
Past history, no history of previous blood transfusion, vaccination, trauma, or exanthematous fever before the onset of illness. Antenatal history, The firstborn child to a third-degree consanguineous parents to a primary mother, age of conception by 21 years, confirmed by urine pregnancy test by 2 months of amenorrhea, registered at nearby PHC, no history of fever, vomiting, rash or lymphadenopathy, no history of drug intake or radiation exposure or blood transfusion or bleeding PV, and antenatal scans at 3 months of age were normal. Iron and folic acid supplementation were taken, TT prophylaxis vaccination was given, quickening was felt at fifth month of gestation, no history of PAH, gestational diabetes mellitus, thyroid disorders or drug intake or radiation exposure by second trimester, and anomaly scan done which was normal. Third trimester interval growth scan was normal and no history of diseases complicating pregnancy, no history of antepartum hemorrhage. It was a full-term normal vaginal delivery conducted at tertiary hospital. The child weighed around 2.9 kg, appropriate for gestational age, and cried immediately after birth. The child was given to the mother after 1 hour of the birth, and breastfeed was initiated after an hour. Passed urine and meconium on day 1 of life. Child was discharged from the hospital by day 3 of life after immunization. No history of neonatal seizure or jaundice or sepsis or respiratory distress. Family history, parents has been noticing similar complaints in the younger sister who is under evaluation now, and no family history of unexplained death. She is born to a third-degree consanguineous marriage, and there are 2 girl children, and both of them are affected. The younger sister is now 4 years old. She's developmentally normal till 4 years. Symptomatic since last 4 months. The symptom was insidious in onset of gait abnormality in the form of toe walking. There is no regression on speech, cognition, or vision noted. The evaluation of this child is pending.
Hi, what do you think is the mode of inheritance from your family history? Most likely mode of inheritance. You can show you the pedigree chart.
Autosomal recessive.
And why? Yeah, and why? Yeah.
Consanguineous parents, history of consanguinity is
Third-degree consanguineous marriage, sir, and both the children are affected. It could be autosomal recessive, sir.
Good. So most likely it is autosomal recessive because the transmission is more like vertical, right? Like an consanguinity. Okay, good.
Safa, if any other inheritance you want to consider with this pedigree, what is the other inheritance you will consider?
X-linked recessive, sir.
Which one?
X-linked. Mitochondrial inheritance.
Yes, mitochondrial inheritance is something which you can consider. Okay, we talked about something called Rett syndrome just now. So what is Rett syndrome's inheritance?
X-linked dominant.
X-linked dominant. So what does X-linked dominant and X-linked recessive mean?
X-linked dominant affected the child to all the doctors.
You need to come closer to the mic. So I'll just make the question short.
X-linked recessive, the male children will be affected, sir.
Yeah.
Females will be carriers, sir. X-linked dominant mother will. Female childs will not survive, sir.
What are the phases of Rett syndrome?
Features of Rett.
Because you
Child will be
mentioned, of course, in this case, you're not thinking about it, but having committed, so they may ask you sometimes questions on this. Okay, proceed.
Of the hand, intellectual disability will be there, sir. Microcephaly and speech delay will be there, sir.
Right. Okay. So thanks. You can move to the next slide where we left off. So immunization seems to be okay, but you're worried about these 2 vaccinations. Why?
In children with a neurological disorder, there will be chances of recurrent.
Not audible. Suddenly everything is silent there.
Sir, in a children with neurological disorder, there will be chances of recurrent respiratory tract infections, sir. So we have to give them pneumococcal vaccine or influenza vaccines.
Someone else is talking, but we're not able to hear what she is talking.
I think
Sir, is a child with a chronic neurological problem, a recurrent respiratory tract infection is a expected complication, sir. So annual influenza vaccine should be given, sir.
right. Okay, thank you. Safa, move to the next slide. So
The diet
dietary
is-
history, do you think anything significant, or else we'll move quickly? We'll start discussing.
Child takes a longer time for feeding, the like 30 to 40 minutes, a prolonged time, but there is no regurgitation or choking, sir.
Okay.
150 kilocalories of deficit and 2 grams of protein deficit is there.
All right, next.
Socioeconomic, they belong to a upper lower class according to
This is
modern
okay, can skip this.
perception history. Mother is aware that the child's neurological problem is chronic progressive and it runs in families, and the disease can be managed with supportive measure to improve the quality of life, but the disease has no definitive treatment.
All right. So is this history complete now?
Yes, sir. Moving on
So
to
what do
summary.
what do you summarize of the history? Can you quickly summarize before going to examination?
8-year-old female child, firstborn of third degree consanguineous marriage with similarly affected younger sister, had smooth perinatal transition with pre-existing speech delay, presenting with a progressive difficulty in walking since 4 years of age, which is associated with a gradually progressing generalized dystonia with preserved cognition, intact vision and hearing, without episodes of acute decompensation. The syndromic diagnosis would be early childhood onset neuroregression involving the basal ganglia.
Right. Ranjit sir, any questions on this?
Oh no, it's very well nicely summarized. Just quickly some other negative. So basically, when we neurodegenerative, you said you need to bring out gray matter, white matter, basal ganglia predominant or spinocerebellum. So you brought out basal ganglia. You need to rule out the other stuff from the gray matter. So I would add definitely no history of seizure. In addition, in your negative history, in the summary also,
Okay,
and yeah, so that's very significant because that's one of the common presentation of gray matter illnesses, and some core or I would say pertinent negative points. So which also you should come in your with relation to etiology. Jaundice, I would say, is very important because Wilson's is one of a common entity. So no history of jaundice, and also vision you clearly said. So that's nice. So I think it's good. Yeah, it's a nice summary.
Right. So with the summary, let's go to the examination. And
so before that, like etiology, yeah. So you pointed physical summary and localization. Any etiology? Or do you have any clue or any possible etiologies?
So what are the kind of disorders you expect with such of a presentation? Early childhood onset, there is neuroregression, primary basal ganglia involvement. What would be your groups of differentials?
The child has Wilson's disease, Huntington's chorea.
So basically, you're thinking of Wilson's and Huntington's are neurodegenerative disorders, no? Genetic neurodegenerative disorders. You're thinking of neurodegenerative disorders, right? From a genetic basis. That is one group. So the disorders typified in that group are one, Wilson disease. Second, you would think of much rarer thing which is seen in children, childhood onset Huntington's. Other than that, anything else you want to keep higher up the cards? Yes, PCAN, yes. These fall under a group of diseases called what? Neuronal brain ion storage disorders, no? Neurodegeneration associated with brain ion accumulation, right? Okay. So PCAN stands for what? Right. Any other disorder handling metal ions leading to neuroregression, dystonia, which can present in the very similar age group? So Wilson is one, yes. PCAN or a ion disorder is one. Any other metal ion you can think of? Menkes not in this age group. And what is Menkes? Again, inheritance of Menkes.
X-linked X-linked recessive, sir.
So can you, no, one more disorder which you have to think of, another metal ion.
Manganese.
Yes. So manganese transporter defect is another disorder you should think of. Okay. So yes.
So I will also add no history of organomegaly or no history of abdominal distension, because neurodegenerative lysosomal storage disorder is a big category. So just quickly you can add that. So do you think any form of lysosomal storage disorder is possible?
Sir,
So
Sir, there is no.
no, you had, yeah, correct. Yeah.
Mucopolysaccharidosis or Gaucher's disease.
Yeah, very unlikely with this presentation, right? Okay, go ahead. Yeah.
So any other group of disorders, Safa, before this? Another group of disorders you got?
Neurotransmitter deficiency, sir.
Yes, especially because you say cognition is preserved, no other, neuro parts of the neuro axis are involved. You're just having dystonia, though you don't have other classical features like diurnal variation, like asymmetrical onset, or in the case of very early onset disorders, no, you don't have they are very severe. Just you had mentioned something called AX, which present in infancy with severe developmental delay and autonomic features. Autonomic features are also not there. So that is a possibility. Any other group of disorders? Why had you mentioned without episodes of acute decompensation?
Mitochondrial.
So what large group are you trying to, rule out at this time point? Neurometabolic disorders. Yeah. So you had mentioned mitochondrial. You had mentioned organic acidemias. Okay. So which organic acidemia presents with episodes of decompensation and progressive dystonia and developmental delay as time progresses? Which organic acidemia would you think of? Glutaric aciduria is one prominent organic acidemia which presents with extrapyramidal features, but they have classical episodes of decompensation. So these are all the broad groups of disorders you would like to consider. So let's move quickly to the examination.
Child is conscious oriented, no pallor or icterus or lymphadenopathy. Attitude, child is sitting without support. Intermittent involuntary non-rhythmic flexion and extension of neck. Face, meaningless fixed smile, repeated closing and opening of mouth with tongue thrusting. Inability to fully open the eyelid with brow overactivity. Upper limb, right upper limb, shoulder in adduction, elbow in extension, wrist in flexion and flexion of other fingers. Left shoulder in adduction, elbow in flexion, wrist in flexion and opposition of thumb. Lower limbs, hips in adduction, knees in flexion and ankles in plantar flexion and equinovarus of both the feet. Posture of both limbs are asymmetric and variable.
So Safa is a very detailed description of the child's attitude and posture. But do you think this is something which is fixed or keeps varying in this child? You had observed this child for a long time, right?
Constantly varying, sir. It's not fixed.
Yes. So instead of describe this is at a very particular time point. This dystonia, children with dystonia, particularly this disorder, have variable tones and postures. That is the hallmark of their, movement disorder. So this is just at one time point, but you can observe, on serially observing them, you can see that their, postures keep varying, right? So let's move to the next one.
Just what do you make out of that inability to fully open the eyelids with brow overactivity? That's very catchy. So what do you make out of that?
Probably due to blepharospasm, due to dystonia,
So
you are staying very far away from the mic, right? Okay, yeah.
Any comment?
Blepharospasm, sir.
Yeah,
okay.
Sir, I want to know any comment about the faces. Face, any abnormality seen, any malformation?
Yeah, so dysmorphic faces is what sir wants to look for. So do you feel this face is dysmorphic, Safa?
What about the ears, normal position?
no dysmorphic faces. I will tell you about it at head to foot.
No dysmorphic faces, sir.
Okay, fine.
Right. So what about the general examination? Go ahead.
Head to toe examination, head size and shape is normal, hair is normal, eyes no, KF ring, no cataract, no telangiectasia, no oculometer apraxia, no gaze palsy. Ear, nose and throat are normal. Mouth dentition is normal. Faces, no dysmorphism. There is a healed scar in the forehead. No neurocutaneous markers, no signs of vitamin or nutrition deficiency, or no gross congenital malformation. Equinovirus of both feet, no bed sores, bilateral ankle contracture is present. Vitals: temperature afebrile 98.4 degree Fahrenheit, pulse rate 110 per minute, regular rhythm, volume normal, no radial or radiofemoral delay, respiratory rate is 28 per minute, thoracic in respiration, no retraction, pulses are well felt in all peripheral vessels, saturation is 98 in room air, BP is 90/60 in the right upper limb in the supine position. Anthropometry: weight is 16 kg on 10th centile and normal, length is 110 centimeter, it falls below the 3rd centile. It comes under stunting. BMI is 12.9 kilogram per meter square on 10 centile. It's normal. Head circumference is 49 centimeter. It's normal. Moving on to central nervous system examination. Higher mental function: alert, recognizes caregivers, obeys simple commands, it's playful, amicable, answers in a single word to simple questions, shows 3 body parts, speech is variable stress on syllables. Lobar function: frontal, emotional response present and appropriate, social behavior, no disinhibited behavior, attention is fair, temporal, language comprehension is intact, naming and repetition not able to do, auditory perception, speech and music intact, memory testing could not be done. Appreciation of size, shape and texture is present. Facial orientation right and left is present. Apraxia: it is know how to dress, but it requires assistant to perform. Occipital: it recognizes faces and colors. Motor system examination: bulk, there is no wasting of muscle, and tone, the varying tone in the form of intermittent hypertonia and hypotonia seen in all 4 limbs. On examination of the tone on physical manipulation and on spontaneous movement during testing of power, dystonia is observed to increase in both upper and lower limbs. Power is observed, best observed power is above, is more than 3/5 in all the muscles around the joints. Reflexes: superficial reflex corneal was not tested, conjunctival reflex is present, bilateral abdominal reflex is present, plantar reflex withdrawal response in both the limbs, lower limbs. Reflexes are elicitable, cortical release signs and primitive reflexes are absent. This is a gait of the child. Stance noted to be wobbly on standing without support. Gait was broad based with bilateral toe walking, right more than the left, with intermittent sudden plantar flexion and inversion of feet requiring high stepping to clear right off the ground. Difficulty in turning without assistance. Right upper limb was noted to have flexed and twisted posture in addition to the involuntary irregular non-rhythmic movement. Left hand was always used to hold on to the mother for support.
Therefore, do you have a video of the speech by any chance? No?
Yes, sir.
If you have that, you can play for others' benefit. But that is okay. If you don't have it later on, we can play. You can just finish the examination. We'll do it in the discussion.
Okay, sir.
Yeah.
Cranial nerves: first nerve was not tested. Direct and indirect light reflex is present. Fundus cannot be tested. There's a continuous dystonic movements of the neck, and visual acuity, field of vision and color vision cannot be examined. 3, 4, 6 extraocular movements were full, and able to chew food and conjunctival reflex is present. 7, no facial asymmetry, no drooling of saliva. 8, hearing normal, turns when called. 9 and 10, gag is present and palates equally moves on both sides. 11, able to turn side to side, and 12, able to protrude the tongue without deviation. Sensory system: withdrawal to painful stimulus, grimace to pain. Cortical sensation could not be tested. Cerebellar signs, no nystagmus, other signs could not be elicited. Autonomic system is normal and spine is normal. Extrapyramidal signs: generalized dystonia is present. involuntary repeated non-rhythmic twisting movements of both the upper limb with abnormal posturing, and intermittent arching of the neck, repeated opening and closing of the mouth was present.
Great. Could you observe any abnormal eye movements of how, why is it significant to observe the eye?
There were no abnormal eye movements for dystonia involving the oculomotor apraxia.
Oculomotor apraxia, yes. Yeah. So oculomotor apraxia is usually tested and it also can be observed. But
gaze palsy
is another important thing, yes, you had mentioned. What you have not mentioned, there is one extrapyramidal movement of the orbital musculature, ocular musculature, which you see in certain group of disorders which you had already mentioned, neurotransmitter deficiency disorders. What is that kind of a movement? Have you heard of anything called oculogyric crisis?
Yes, sir, oculogyric crisis.
Yeah. So in which group of disorders you find them? You find them in neurotransmitter deficiency. Yeah. So they are rotatory or torsional movements of the orbital of the eyeball, basically due to dystonia of the orbital musculature. This is very classically seen in disorders such as AADC and other early onset neurotransmitter deficiency disorders. Right? This is just for you to know about it. Move to the next slide. So have you completed examination? Is there anything left?
Other system examination, sir. It's normal, no cardiovascular system, no murmur, apical impulse on the 5th intercostal space, medial to midclavicular line. Respiratory system, errantry equal, normal vesicular breath sounds, yes, no added sound. Abdomen, not tender, not distended, no organomegaly. Summary, sir.
Sorry, did we hear about fundus? Maybe I have missed that.
Fundus cannot be tested, sir. The
You
child
could not test it. Okay.
Did I miss the tendon reflexes, Sivan? Did I miss the tendon reflexes?
Sir, we had mentioned it here, sir.
Oh, I see. Sorry. What is it? Normal. Is it?
So the reflexes are normal, sir.
Normal.
Yes, sir. Yes, sir.
Thank you.
So, Safa, what if you don't get the knee and ankle jerk in this child? What does it signify? And what if you get a very brisk knee jerk and ankle jerk and elicit knee and ankle clonus? What does it signify? Yeah. What?
Pyramidal tract involvement. Sir.
Yes. So now you want to see whether, the disease process is involved only the basal ganglia or other facets of the neuroaxis have been involved.
Yes.
Okay. So in this particular child, if you are not going to find, pyramidal tone superimposed on extrapyramidal tone is very difficult to make out. Okay. So when you find other signs of pyramidal involvement, so tone is one abnormality. Hypertonia in the form of spasticity is one pyramidal sign of pyramidal dysfunction. What is the other sign? Brisk reflexes and presence of clonus in the severest forms. And what is the third sign of pyramidal involvement? Extensor plantar. Yes. So when these are involved, then you can make an assumption that the pyramidal tracts are also involved by this disease process. And what if the reflexes are not present?
In cases of peripheral neuropathy, ankle jerk will be absent, sir.
Correct. So when a child has dystonia as well as peripheral neuropathy, you won't be able to make out the weakness part much. And in this particular child, probably testing for sensations until a very late stage may be not very fruitful. So absence of the ankle jerks and absence of the knee jerk can tell you that there is a superimposed or additional neuropathy in addition to all these findings, right? Okay. Yes. So yes. So let's go to the summary. If anyone else has any questions on this, you can go ahead, sir.
Yeah. So you nicely pointed out the dystonia. So what about other movement disorders? Like a wing beating tremor or a tremor or athetosis, chorea. If not, you need to bring it out in your to the examiner. It's
The
not
other
that.
students have any other this thing, information to add?
No other involuntary movements found in this patient.
So how would you test for, sir, is meaning to ask, how would you test for the other movement disorders? Like, how would you test for the wing breathing tremor?
Ask the child to extend the hands and with the palm face outside, sir. If the flapping tremor is present, it will fall down, it will flap. In case of Wilson's disease, flapping tremor.
So you are looking for something called negative myoclonus or asterixis, right?
Yes, sir.
Yeah, so you make the child, extend the upper limb, and if there's an involuntary drop, you think of that particular movement disorder. Negative myoclonus, again, myoclonus is a movement disorder as well. So that is for negative myoclonus. Okay, any other movement disorder you want to check for?
So for chorea, we can check. For chorea, we can check from milkmaid grip, spooning of the hands, darting movement of the tongue.
Yes, yes. So these are all maneuvers wherein you can check. So that is one maneuver to check for chorea in the case of, it's very classically described in Sydenham chorea, but it can be seen in other conditions as well. Any other maneuver where we can use?
For sensory tricks, sir. In dystonic spasms, it will disappear on touching the child.
Okay. So that is, and that another, that again says that this movement disorder is probably dystonia. Okay. So that is one thing. And anything else?
Tremors can be tested with the extended limbs.
Yeah, so what sir had mentioned, no, wing beating tremor, how would you test for that? What is the posture you want the patient to stand in, or use his put his limbs in, upper limbs? How would wing beating tremor look like?
Shoulder abduction, sir.
Something like this, right?
You cannot.
So yes, you have certain maneuvers where you want to, you can, elicit certain kind of movement disorders. So that also should be mentioned, right? So let's go to the summary slide. So at the end of history and examination, what have you made out?
Dr. Shivan,
Yes, sir.
I want to know whether any specific drug related to dystonia was administered and that trial was done.
Yeah, history wise.
What drug I am talking about, madam?
Levodopa, sir.
So any treatment was given in that direction?
No.
Or they?
No. Mother didn't know the details, sir. She told she has given some medications only. She didn't give us the correct details, sir.
So what kind of a response would you get in a child with, dopa responsive dystonia when you give him this particular medicine, what sir has mentioned?
There will be improvements, sir.
Is it just improvement? How would you describe it? Wouldn't be dramatic?
Or dramatic improvements.
Yes, dramatic improvement would what the parents describe, right? So that is one important history probably which we failed to mention, but has to be mentioned.
I wanted to know from Shivan and our Ranjit whether they had any case and what is the response immediately to this treatment. Sir, you must be having enough cases, or one or two cases at least.
Sir, it's not maybe at least like whatever I have seen, it's not that common as maybe one or two cases.
Common, but at least you must have had the experience of treating.
One or two cases every year, maybe. Particularly lower limb onset dystonia, unexplained, you should definitely give. So we always say like any child who is presenting with the dystonia without any specified cause, you should give a dopa trial. It's a kind of a diagnostic trial itself.
And the
Can
response.
I add one more thing?
Right.
Can I add, Sivan?
Yes,
Yes,
sir.
sir,
Dr. Cooperation, I want to hear your voice.
So the other thing what they use to say in every spastic diplegia, a trial with the dopamine is important to make sure it's not a dopa responsive dystonia. The
Right.
clue to a dopa-responsive dystonia would be a family history. Second, the fluctuation. The site starts sick, and as the day improves, it improves better. These two things will give you a clue for a dopa-responsive dystonia. Thank you.
Thank you, sir.
Thank you, sir. Nice to hear your voice.
Thank you, sir.
So I think Safa, you can go to the summary slide. So how would you like to analyze this case? How would you like to summarize at the end of history and examination?
8-year-old female child, firstborn of
I
third.
think you have mentioned it. So I would want your analysis of this case. So probably the next slide.
Onset of regression is around 4 years of age. The type is insidious onset and chronic and progressive. The predominant sector involved is the motor, and predominant clinical manifestation is dystonia. There is a presence of other neuroaxial involvement is not there, and presence of extra neurological features are not there. The anatomical localization and substrate involved would be gray matter deep. This is basal ganglia. The syndromic diagnosis is early childhood onset neuroregression involving basal ganglia.
Okay, so if we remember right, at the end of history also we had the same syndromic diagnosis. So what has improved after examination? So what have what are the causes among these three groups of disorders? Neurometabolic, neurodegenerative, neurotransmitter disorders. What do you think is the order which you would like to keep the differentials?
The neurodegenerative disorders, sir, because the other neuroaxial.
Sivan, can I add one more doubt?
Please, sir.
Is the gait purely extrapyramidal, or is there an ataxic gait? The gait does not seem to be totally extrapyramidal. Am I right?
Sir, we had this doubt as well, sir, but we did not want to, because we did not have any other
But
overt.
some high stepping gait was there, no? She was able to lift that much the toe.
Sir, that was because he had a very severe equinovarus of the right foot. So because she needed to clear that right foot off the ground, she adopted that kind of a posture. But sir, she
explained it very well. Yeah.
Yes, sir. So the presence of a cerebellar involvement could not be grossly ruled out looking at her gait, because her stance was very wobbly and she had swaying even while sitting, and on walking it exacerbated, but she did not have other signs of overt cerebellar involvement, hence she did not bring it up to discussion. So probably there is a component of cerebellar involvement in her gait especially and her stance, but probably not overshadowing her extrapyramidal problem.
No, the reason why I brought was, should I change the discussion the pure extrapyramidal or extrapyramidal plus? Then the differential diagnosis could probably narrow down a little more.
Right, sir. So we could still consider this child to have some degree of cerebellar involvement, but sir, I would like to say that it is not as prominent as that seen in probably a child with Wilson's disease. So for the residents and the fellows, Wilson's disease, though present with a very prominent dystonia and a Parkinsonian phenotype, they generally have some signs of cerebellar involvement as well. So that is how you pull out Wilson's disease phenotype from the other causes of childhood onset neuroregression involving basal ganglia. And also that there are mitochondrial disorders which generally involves multiple parts of the neuroaxis. So a prominent component of ataxia would still make mitochondrial disorders higher up on the cards of differentials. So in the case analysis, so coming back to the question, Safa and Swati and Gomati, how would you order your differentials? So you want to keep neuroregression first or neurometabolic first?
You would keep neurodegeneration first, then neurometabolic.
Yes, followed by neurometabolic. So among, do you want to keep neurotransmitter disorder still in this list?
But Shivan Keshan, I want to ask you one doubt. Can I ask you?
Yes, sir.
So you said, you have classified into two different conditions, but of course, neurometabolic itself can have neuroregression. Yeah, isn't it? It both can coexist. Some of the enzyme deficiencies.
Yes, sir. Yes. So on a strict point of view, all neurometabolic disorders are neurogenetic disorders, and in a certain way they are neurodegenerative also. But just for keeping the differentials and for the residents to understand the disorder. So the syndrome is neuroregression. The groups of disorders are neurodegenerative. That means the genetic neurodegenerative, meaning Wilson, Pecan, your manganese transporter and all that, Huntington's, as you had mentioned. The second group would be neurometabolic, considering organic acidemias, mitochondrial, and all these group of disorders. And the third one would be neurotransmitter disorders, where you have disorders including dopa-responsive dystonia, as we had discussed, and the very severe phenotypes of AADC and other kinds of neurotransmitter disorders in infancy. So among
Sivan, I'm subject to
Sir.
correction. Does acanthocytosis come into picture?
Yes, sir, it does come into picture, sir.
You mentioned acanthocytosis based on Condon's disease.
Yes, sir, definitely, sir. Though it is not very commonly seen among these differences, probably it would feature much lower. But yes, acanthocytosis, neuroregression associated with acanthocytosis and retinitis pigmentosa is called NARP. So this entity also is a neurodegenerative disorder. It can be easily diagnosed with peripheral blood smear.
Yeah, but in acanthocytosis, usually it's cerebral will be dominant over the extrapyramidal, no? Am I correct?
Yes, sir. They can have a prominent dystonia phenotype, chorea phenotype, as well as cerebellar. Both can be present, sir.
Okay, sir.
So, yes. So, among this group, coming to the question again, Safa.
Yes, sir.
So, do you want to keep neurotransmitter in this list?
Yes, sir.
Yes.
Dopa-responsive dystonia and amino acid decarboxylase deficiency.
Yes. So,
but there is no diurnal variation or sequential involvement of the dystonia on the limbs.
Okay. So among dopa responsive and the other thing you are told, which one would you keep more higher in the first one, right?
Dopa responsive will be first.
Yeah, because it is a later onset phenotype. Dopa responsive generally is also later onset. This child had symptoms only after 3 or 4 years, if I'm right.
Yes,
okay,
sir.
the other disorders are very severe. So probably this one you would keep. And because it is a treatable entity, you will keep it, higher on cards and give, a trial of whatever the diagnosis turns out to be is not the question, but you will still keep it because it is treatable. And very important points are that this child has preserved cognition on all the other modalities seem to be preserved. So only dystonia and the motor regression seem to be the presenting phenotype, which is the classical case with dopa responsive dystonia. Though you don't have the asymmetrical onset or unilateral onset, then sequential involvement, diurnal variation and all that. Okay. And dopa responsive dystonia have oromandibular or facial involvement very late in their disease course when they are not treated for a very long time. Generally, they're limited to limb dystonia. Yeah. So that is another point. Okay. So you would keep this, and neurodegenerative disorders is what you have told me. And neurometabolic, you want to move down. Why?
There is no episodic involvement, metabolic crisis, anything, and no other neuroaxial involvement. Other neuroaxes are normal, and systemic involvement is also not there. So
you don't want to consider neurometabolic disorders, but still, is there a neurometabolic disorder phenotype which can present like this without any, real acute exacerbations? Is there any group of disorders? A vast group of disorders which comes under mitochondrial disorders, right?
Yes, sir.
Mitochondrial disorders, there is just a very vast term. We have multiple phenotypes in that. So you need not have acute exacerbations every time. In certain phenotypes, in certain disorders of mitochondrial dysfunction, you can have such a chronic progressive course instead of an acute intermittent exacerbative course, right? So let us go to the next slides. Do you want to discuss the odds against and for points against each diagnosis quickly before we move to the investigations?
Steven, can I ask one question to her?
Sure, please.
You have considered Wilson's disease. You have excluded Wilson's because there is no KFL. My question is, what are the conditions of Wilson disease where there can be no KFL still? Because it's a treatable condition, I will keep it very high in the card just because it is not KF ring, should I still rule out Wilson's disease? What are the conditions where Wilson disease, KF ring can be absent? I don't know whether if the question is too tough for them, leave it off.
Do you want to take up one of you?
It is age of onset of the disease is earlier for Wilson, sir. Wilson's will be in the school going children 5 to 15 years. And initially they present with the aggressive psychiatric behavior will be the initial manifestation. And certain Wilson, there will be no KF ring, sir.
In an exam, the simple way I would like to escape is a treated case of Wilson's. KF ring may disappear. We had an old statement, I don't know how much is true today, absence of KF ring with neurological signs excludes Wilson's disease. Probably these 2 points, I don't know whether Professor Srinivasan and other examiners will accept it.
When population says everything will be accepted because your experience and so vast, so we have no this thing because we see only occasional cases, but you have been seeing and working up these cases. So that's why we are all depending on you for your this thing valuable.
100%.
Sivan's comment. Sivan's comment, please. Dr. Sivan and Ranjit's comment. Whether it's outdated statement, I'm an old man, outdated statement are still currently valued.
But you are absolutely right. So it is said like in Neuro Wilson's 95 to 98% KF ring is seen. But it's not only naked eye. So we need to do slit lamp also. Just not ruling out by naked eye is not enough. So you are right. 95 to 98% Neuro Wilson should have KF ring. Yeah.
Sir, if I can tell about yesterday's case, sir, in Apollo Hospital platform, can I tell about Wilson disease? Just 2 minutes. This child was presented with only 10 days, 3 days of fever and subsequently yellow colored urine and jaundice. And subsequently, of course, the child was having. And everybody was, Dr. Balak Subramanian and myself, we were there discussing the case along with some of the senior state professors. So we are talking about various infective conditions like leptospirosis and other conditions. Okay. But of course, the candidate after discussions, he put Wilson disease as the second diagnosis in such an acute short this thing, but liver was only 2 centimeters, no splenomegaly. Okay. And subsequently, I told the student, see, if you have put and it happens to be Wilson disease, people would think that you have been tipped by the in the examiner by somebody and this thing, because it doesn't look like such an acute onset without spleen and without a normal feeling of liver. Finally, it turned out to be Wilson's disease, and it seems they have done transplantation also in this child. Surprising. This is the first time I'm seeing such a case. It may be available. If it is available, I will send you that this thing link.
Thank you, sir.
Thank you.
Sorry to interfere. For postgraduate teaching, Wilson can come to any department. It can come to hematology for acute hemolytic anemia. Can come to hepatology for acute jaundice, portal hypertension, hepatosplenomegaly. Can go to renal department for renal tubular acidosis.
Yeah, here
can go to orthopedic
department
for it can go to any department. That's why I remember to write the theory of Wilson's disease. I take one department to another. I'll give all the clinical features without missing any one of them.
Thank you,
Sorry,
sir.
I'm talking too much. Right.
That's a very well taken point, sir. Yes. So among your differentials now, you have discussed the groups of differentials. So can you go to the metabolic disorder slide? So among the neurodegenerative disorders, so among the neurometabolic disorders, do you want to consider, if you want to consider one metabolic disorder, it would be?
Mitochondrial disorders.
One mitochondrial disorder as a broad group. Okay. And?
Organic.
Yeah. Organic acidemia, but without, episodic exacerbations would be less likely. What about glutaric aciduria? What is that examination finding which you want to see in glutaric aciduria patients?
Macrocephaly will be there, sir.
Macrocephaly. In most of majority of patients, you will find macrocephaly, right? And generally, by 6 years of age, they must have suffered at least one metabolic crisis. It's very unlikely that they haven't suffered, but it is not unknown. So if the child has, still, if you want to consider a metabolic disorder in this particular context, you would still think of, you should not think of, probably you will add this to the list. And why not Lesch-Nyhan syndrome? Again, dystonia, developmental delay. Why not Lesch-Nyhan syndrome?
It's X-linked recessive, sir. It's a female child.
Yes.
And
for the same reason, because it is same reason we didn't think of, when you had listed the disorders, Menkes disease, right? Menkes obviously will not have a presentation at this age, at this particular, with this particular clinical syndrome, but that is again an X-linked recessive disorder. This again is an X-linked recessive disorder. You would not expect it to manifest in females, right? But so Lesch-Nyhans do not generally progress to walking. So this child is a child who walked, right?
Yes,
and they have, by this time, by age 5-6 years, they'll have very prominent behavioral manifestations, including self-injurious behavior, mutilation, aggression, leading to consultations with the psychiatrist, right? And then storage disorders. These are all late onset forms of storage disorders, right? Typically, storage disorders in the early onset forms present in infancy.
Yes,
right?
sir. Yes, sir.
So these are late onset forms of storage disorders, but they have other features, including prominent cognitive decline, seizures, myoclonus, organomegaly, and gaze palsies, as you had mentioned. So among these, you have your favorites now: organic acidemia, mitochondrial. Yes. Among the second group,
would be
just one question.
Sir.
If there are any pediatric neurology trainees under the neurometabolic, would you consider peroxisomal also? Just wondering, like, just if there are any pediatric neurology trainees or fellows there. Yeah.
Sir, I think we could still consider peroxisomal disorders as this group. The large molecule disorders presenting at this particular age, because peroxisomal group of disorders is a huge group of disorders with variable manifestations. So we have a very early neonatal form of adrenoleukodystrophy, then going on to, up to Refsum disease in adulthood. So peroxisomal disorders, also acyl-CoA dehydrogenase deficiency present with such a clinical picture. So that also can be included under the differentials. Thank you, sir. And among neurodegenerative disorders, Safa, would you consider Wilson in this child?
Sir, age of onset of the disease is earlier.
So, the rule we have been taught that less than 5 years do not consider neuro-Wilson. Right? Yeah, yes. Generally it is of the later childhood, something from 6 years of age onwards. But the most cases we see onset is after 9-10 years of age. Right? The second decade is a classic description. And prominent behavioral problems, cerebellar involvement, as we had mentioned, presence of KF ring, and Wilson's do not survive for 4 years without therapy. The child had onset of symptoms at 4 years of age. Child is, walking to you with some assistance. That cannot happen in untreated Wilson's disease, right? And another treatable entity which I want you to consider is hypermanganesemia or manganese transporter defect. Okay, so this is another disorder which can be treated with chelation. Right, there is sodium mediated calcium chelation therapy which is available, which can ameliorate the symptoms and decrease progression. Right. The other disorder which you want to consider is called PCAN. So PCAN has vision changes, pigmentary retinopathy, which we could not assess very well in this child because she was not cooperative and fundus examination is not done. So
will you please expand the PCAN because I am not aware of that.
Safa, can you do that?
Sir?
Expand PCAN.
Pyruvate kinase. Okay, I know the other name. Pyruvate kinase. Okay.
Pantothenate kinase is associated neurodegeneration.
Yeah. Now I got it. Yeah.
So childhood onset
appearance. Tiger eye appearance. Yes.
Tiger eye.
Childhood onset Huntington's is again rare. Okay, not a very common entity, but they have very prominent cognitive decline, seizures before the onset of, the day. Huntington's is called Huntington's chorea, right? But as a paradox, in childhood onset Huntington's, you don't have a lot of movement disorders initially. They present with cognitive decline, seizures, and then they start having dystonia rather than chorea. So chorea they develop only later, right? Okay. So the other group of disorders we already mentioned, neurotransmitters. How will you, can you move to the next slide? How will you investigate this patient? Let us conclude in the next 5 minutes.
Sir, depends on the diagnosis and based on the history and clinical examination, my first line of investigation would be imaging, sir. I will do MRI brain with MRS, sir.
Okay. So the most useful single test in such a presentation is an MRI. Many patients, you can make a diagnosis, a radiological clinical diagnosis based on pattern recognition on the MRI. And all these are supplementary, which are going to help you in making a stronger point for your diagnosis, right? So can you move to the MRI? Yeah. So what do you find here, Safa? What are these images?
So this is a T2 axial image, sir.
Okay.
And this is a globus pallidus where there is hyper-intense lesion and hypo-intense lesion, sir.
Okay.
And this is
hypo-intense somewhere below. So you just move your pointer. The black area, yeah, this is the hypo-intense area. Yeah. Okay.
So this is a eye of the tiger appearance, sir.
Yes, this is called the eye of the tiger appearance. What is this the finding pathognomonic of, rather characteristic of? What disorder?
Pecan disease.
Yes,
Neurodegeneration.
kainate associated neurodegeneration. So why is this? What is the reason for this black appearance? This is iron which is being stored in the globus pallidus. Okay. And the medialmost portion becomes necrosed and glyosed. So whatever is, glyosed and undergoes necrosis and then gliosis subsequently becomes T2 and flare hyperintense. So it becomes white. So whatever you see white is this hyperintensity. This is gliosis in the medial part. And the iron which is deposited is what is seen as a black area, which is hypointense, right? So this is pathognomonic of pantothenate kainate associated neurodegeneration. Okay, this is due to iron deposition. Okay.
I was remembering more as a Haller-Warden spot disease. That's why. Yeah. Thank you.
And to complete the history, sir. Sir, thank you.
Right.
Sir, to complete the history, Haller-Warden spots is a word which has been removed because they were involved in Jewish torture. So now we do not use the word Haller-Warden spots.
I know. Yeah.
For the post, not for you. For the postgraduate, let them not use the word and irritate the examiner. Right.
This has a very interesting historical significance. I think postgraduates can go and read about it. There had been a New England Journal of
because it was an abbreviation, immediately I didn't get it. Yes, old age,
So yes. Ranjit sir, any questions at this point?
No, it was very classic case. So only thing is, like, if I was an examiner, I may ask you, what is the first step you will do, like in front of conservative? So you said fundus could not be done. I would do a fundus first, because fundus will show retinal degeneration and optic atrophy.
Tigroid appearance.
Yes, sir. Fundus in pecan has fundus changes.
Yeah.
So, and also the next is slit lamp for KF ring, although your naked eye KF ring. So I'm talking about an exam perspective. So, and then once you have done this, go for MRI. Right.
Okay.
Yeah. But anyway, it's a very classic presentation. This is how
Can
usually
Ranjit, for the sake of postgraduate, give a few examples of extrapyramidal disorder where globus pallidum is predominantly involved, extrapyramidal disorder where putamen is involved, extrapyramidal disorder where caudate nucleus. Sometimes when you read the literature, you get confused. Can you concise it, make it for postgraduate and simpler?
So I will take it to MD level, sir. Like when you talk about globus pallidus, I would first think of kernicterus sequelae, sir. Even in India, even now, when we see a lot of kernicterus. So kernicterus is bilirubin deposition, which happens in the globus pallidus, which is very, very common. That is perhaps the commonest cause of secondary dystonia, I would say, in Indian setup. And then comes your pecan, even manganese, all these gets deposited in the globus pallidi. So these are called neuronal iron accumulation disorders or heavy metal disorders. These are the 2 or 3 common entities which I will think of globus pallidus. Coming to putamen injury is putamen is the most metabolic active area of the brain. So you think of hypoxia, it involves putamen and ventrolateral thalamus. So mixed CP, what we call is like dystonia plus spasticity, is usually because of the acute total asphyxia and putamenal injury, necrosis. And then comes your highly other metabolically active condition, that is mitochondrial disorders. Like mitochondrial disorders can involve putamen, they can involve thalamus and other areas of the brain also. Leaks disease. So all these are another common disorders which involve putamen. And then comes your caudate. Caudate classically is described as Huntington's disease. In Huntington's disease, which is a adult onset disorder, Huntington's chorea, because of triple repeat sequence, it happens in predominantly 30 to 40 years of age, adult presenting with chorea. But the I think it's the Westphal variant of Huntington's can present in the juvenile form, and they present more with dystonia rather than with chorea. So they can have caudate atrophy. And our rheumatic chorea also is the injury seems to be more likely to related to caudate. The antigens are more related to caudate than other. So these are some of the common disorders, I would say. Maybe if I have missed anything, you can add some
Thank you. Thank you.
I remember C caudate for chorea. So that's who I remember. C for C. Yeah.
Thank you.
So just one question to the presenter, like any treatment options for PCAN? I'm sure you would have read about that. And
Definitely.
yeah, we do try iron chelation. So make sure the iron levels, you check the iron levels, hemoglobin and iron levels, because it can lead to depletion. So there is some evidence for that. Yeah.
All right. Sir, do you want to just...
So how much time do we have, Shivan? I will customize according to that. How much time do we... 10 minutes?
Actually, no, we have kind of go short by 15 minutes, but doesn't matter. Probably another 10 minutes.
Yeah, just I'll wind up in 10 minutes, sir. Can you enable?
That's fantastic.
Yeah. So just for showing them some of the... So I will not go through the... so do you see my screen?
Yes, sir.
Yeah, that's fine.
Yeah, I can see 3 students. So it's more like an ASCII for you. I'm sure Srinivasan sir have seen this, because every year in RIPE, we used to do this. So now after the COVID, we could not do it. So it's a heterogeneous disorder. I'm not going to all those details. Remember 2 key features for neurodegenerative disorders: regression and progressive neurological deterioration. It's not only regression. You need to have progressive neurological deterioration, which is progressive loss of neurological function. You can read about this. So we classify them as polio, leuco, diffuse, coencephalopathy, and spinal. Polio is gray matter, leuco is white matter. So infantile onset, late infantile, childhood, juvenile, age of onset is very important. So we have a mnemonic, we remember like this: women's, W stands for white matter disorder, O stands for others, like neurotransmitter and peroxisomal, M stands for mitochondrial, E stands for epilepsy predominant. Here we are talking about progressive myoclonic epilepsy. Remember, SSP is also one of the common conditions in India where they can present with neurodegenerative symptoms. And N stands for neurotransmitters, and S, major chunk, that is storage disorders. So just, I always look only at 5 points. What is the age of onset? Am I dealing with the early onset, late onset, childhood, or juvenile or adult onset? So your situation seems to be somewhere between childhood onset, right? Your case. So you have certain disorders which starts with childhood onset. So PCAN is one classical example. Early infantile onset, Krabbe disease. Late childhood or late infantile or late infantile, metachromatic leukodystrophy. Juvenile, Alexander or adrenoleukodystrophy. Adult onset. Do you know any adult onset neurodegenerative disorder? Safia, I don't. Sorry?
Multiple sclerosis. Multiple sclerosis, sir.
So multiple sclerosis, that's a relapsing condition. There is a condition called Kuff's disease, which is neuronal ceroid lipofuscinosis. Adult onset. So you can even have adult onset degenerative disorders. Then once you have done what is the age of onset, you should see, is it a progressive disorder or static disorder, that you know very well. Rule out pseudo-regression. We haven't spoken about that yet. So what are the 5 major causes of pseudo-regression? Pseudo-regression is you have a static disorder like a cerebral palsy, but due to some cause, the child lost some milestones. What are those?
In case of any new onset of spasticity or new onset of seizures, after using any anti-epileptic drugs like phenytoin, valproate, or any newer contractures, HIV, new onset involuntary movements, progressive
Yes. So new onset of movement disorder, like worsening of your tone or spasticity, drug toxicity, drugs, anti-seizure, uncontrolled epilepsy, and I would not forget systemic illness. You know, we have a child who has cerebral palsy, came to the ER and saying that previously child was walking, now the child is not walking. The child had dengue. It's a systemic illness. Even systemic illness mimic like regression, right? So you have to think of those causes. And then you see is a predominant gray matter onset or white matter onset. I want to emphasize all neurodegenerative disorders ultimately go into like regression of everything, right? Like ultimately it looks like same. When you see a 14-year-old child with MLD and a 14-year-old child with PCAN, they may look same because everything is lost by the time. It's the onset which is very important for you to see what is the type of onset. And look for head size, dysmorphism, organomegaly. These 5 points are enough for you to kind of reach a conclusion, make a diagnosis. So I'm not going to 3 slides. I will directly go to the ASCII part. So gray matter, remember seizure, cognition, and retinitis pigmentosa. White matter, tone is the most important. Tone, no seizure, it is a neuropathy component. So you can read more about that. So I'm skipping these slides. We discussed all these things. I'm skipping this algorithm, which is there in our book also. And remember, there are some acquired cause of regeneration also, like SSP, infections, HIV, rubella. Somebody said multiple sclerosis. Yes, these are acquired causes and treatable causes of regression: lead, hypothyroidism, B12, vitamin E deficiency, and drug toxicity. Never forget these treatable causes. In view of time, I'm going very fast. Okay, now just last 5 minutes, ASCII, you have to answer. I think most of you know this. So this is a 11-month-old child who came at 8 months with history of an episode of diarrheal illness, regression, followed by generalized dystonic movements. And we also saw relatively large head size. We did an MRI which showed this kind of an appearance. The clue is here. And we spoke about this condition. So what is the diagnosis?
Sir, bat wing appearance, neurometabolic disorder, sir. Organic acidemia, glutaric aciduria.
Excellent. So macrocephaly, extrapyramidal symptom, regression, glutaric acidemia, bat wing. Okay.
Which type also you have to mention?
Sorry, sir. I did not get that.
Which type also you have to mention?
Okay.
Type 1, sir.
Yeah, type 1. So this child is 11-year-old, came with difficulty in walking, imbalance, unsteadiness, recurrent LRTI. Yeah. So that's it. And progressive disorder.
The child is having
Eyes.
You need to speak louder. You need to speak louder. Come close, Dr. Swati. Yeah.
Look at the eyes.
sir, this child is having left eye ataxia, telangiectasia, sir.
Yeah, good. Both eyes, ataxia, telangiectasia. Don't miss that feature. So this is 2 kids, actually not one. Both of them presented with neurodegenerative symptoms, regression, and refractory seizures. And this is a boy whom we saw in a later. He's around 6-7 years, I guess. And this is like 1 year old. And their MRI shows, angio shows dilated tortuous vessels. The clue is somebody said hair. So that's the clue.
Menkes Kinkies hair disease.
Excellent. He has loss of hair, actually, alopecia, and this is a kinky hair. This is Menkes disease, and this is also copper related, right? Yeah. It's a classic case. We saw child presented with hypotonic symptoms. Actually did not present with neuroregression, presented more with developmental delay. So sometimes neurodegenerative disorders, when they are not even achieving much of milestones, they don't lose. So it's like, so not all neurodegenerative disorders come to you with a classic symptom of regression. That also you should understand. So on examination has excessive, this kind of patches, and this is gum hypertrophy, liver spleen palpable, and Erlenmeyer flask deformity.
Common in Mongolian spoils will be then GM2 gangliosidosis.
Excellent.
GM2 gangliosidosis.
Yeah, correct. You are also great. Okay. So this is how we remember the mnemonic for the enzymes. I remember like this: PGFK, put PGFK, Pompey's, Gaucher's, Fabry's, and Krabby, and put alpha, alpha, beta, beta, glucosidase, galactosidase, glucosidase, galactosidase. So I make a table like this every time they ask. Even now they are asking in exams. So you come to remember this. Okay. So boy who presented with this kind of a
Coarse facial features with the clear corneas and probably leukopolysacchardosis, Hunter's disease.
Yeah, so hunters always have clear cornea, right, for their vision. So remember that. So he's on enzyme replacement therapy. Okay, so this is a boy, 11-year-old, who presented with severe, profound neuropsychiatric symptoms, behavioral issues. Almost you cannot control him. And he presented with psychiatrist. This is the only neurodegenerative disorders which will go to psychiatrist first, not to pediatric neurologist. So
Automutilation. Automutilation.
No, sir. So Dr. Kumaresan GK was saying that Wilson's can go to any, so this disorder can go to psychiatrist. So first to show his behavior and also have a look at his face. The clue is in his face.
Sir, coarse facial features are there, sir.
Excellent, you made out. Sir, he has a little bit of coarse faces.
With the neurological.
Not that coarse like classic hunters or hurlers. No evidence.
Don't forget hypothyroidism, treatable conditions. Make sure. Sometimes you're burnt our fingers for not thinking of thyroid deficiency.
Yes, thyroid is definitely treatable. So this is San Filippo, mucopolysaccharidosis type 3. They usually have severe behavioral symptoms, mild coarsening, and they present to psychiatrist. So we were talking about this condition a lot. So the child came to us with history of some myoclonic jerks, and this is the father. Okay, child did not have movement disorder. This is the father. So identify the movement disorder and what is the cause. He is 40-year-old, and you.
He is having
What is a movement disorder?
chorea, sir.
So he has generalized chorea, classic.
And athetosis also is having distal writhing movements.
It's almost like dancing, right? He's almost dancing. So it is chorea. And what is the commonest cause of chorea in middle-aged?
Huntington's chorea.
Correct. So this one is not coming up. Okay, this is Rett syndrome. Basically, the child is having repetitive hand-raising movements. So see the video. This is, I think, 12-month-old presented with the developmental delay, no regression, and this is the eye finding. So what is the eye finding?
Pendular nystagmus, sir.
Pendular nystagmus.
Marinus conjunctiva.
Your PGs are very good, Shivan. They are picking up very well. So this is pendular nystagmus, and look at the MRI. Maybe not at your stage. So this is T2 weighted MRI. So in T2 weighted MRIs, myelinated white matter should look dark, but we can see they are looking bright. Okay. So this is hypomyelination. So connect boy, child, nystagmus, hypomyelination. This is actually one of the commonest white matter disorders in our country.
Marinus conjunctiva.
Sir, this is Pelletier-Metzbacher disease. It's called PMD. It's one of the commonest white matter disorders.
Yeah, that's what I thought, but told wrong way.
Yes, it's very common, sir. Just 2 minutes more. This you already saw. So this child is from Andhra who came to us, and we saw this eye of the tiger sign, PCAN, classic dystonia. We tried to give deferriprone, but the child lost to follow up, and we even tried to do DBS for her generalized dystonia under the schemes, but I think it lost to follow up, and she had vision problem. So skipping that. So find out the movement disorder phenomena, and you can look at the boy's skin. It is totally pigmented skin, blackish color, and he underwent liver transplantation. The clue is skin pigmentation, liver transplantation, and this movement disorder. So identify the movement disorder and connect all the three.
Choriothetoid movements are there, sir.
Yes, correct. And can you connect the skin and the liver transplant?
Wilson's.
It is classical Wilson's. So they can also have hepatic Wilson's, neuro Wilson's. Yeah. So this is the KF ring, and it's called the eye of the Ponda. Is a Ponda sign. So you can read about this. Yeah. So So this child came to us with a little bit of ataxia and some tonal abnormalities, large head. MRI showed this. This is the commonest leukodystrophy in India. Do you see the full screen? Yeah.
So large,
Good thought.
large
Good
head.
thought. Yes, large head, ataxia, and
Episodic exacerbations, episodic worsening secondary to trauma or viral illnesses. What do you think?
Leukodystrophic subcortical cyst.
Temporal lobe cyst.
good.
Look at the
Megalencephaly.
confident. Look at the temporal lobes. You'll get the answer.
Cystic leaf.
Cystic leaf, subcortical cyst.
Yes. Yes.
Very common, actually the commonest. So this child came again with similar symptomatology, neuroregression, predominant motor, no seizure. So all pointing towards white matter. And MRI shows this frontal predominance.
Alexander disease.
Excellent. So this child came to us with 2-year-old, came with regression in the form of motor, and also there is an evidence of neuropathy. Like you said, the ankle reflex were absent. Yeah.
Metachromatic leukodystrophy, sir.
Yeah. So this is the tigroid appearance, periventricular and sparing of U fibers, classical metachromatic. So this boy came to us with vision problem, behavioral issues, and also hearing problem, no seizure, and he had this hyperpigmentation in the knuckles.
No.
Dorsum of the hand. Yeah, occipital. So adrenoleukodystrophy. So yeah. So if this child has presented with predominant peripheral neuropathy symptoms and the MRI did not show this, what will you think?
Metachromatic leukodystrophy.
MRI did not show this. No evidence of leukodystrophy on the MRI.
Vitamin B12
deficiency, which is very common. Yeah. So this boy, he presented with a severe dystonic crisis following an episode of dehydration.
Self-mutilation.
Leishman syndrome. They even have lip mutilation. You can see this. Yeah. So this child presented with regression. The child has achieved neck control, rolling over, sitting, but lost sitting in the last 2-3 months and became more irritable. This is the clue. This is the easy clue.
Hyperpigmented knuckles.
So vitamin B12 deficiency.
Vitamin B12.
Yeah. So this boy is a follow-up of chronic CK kidney disease and renal transplant, not liver transplant, renal transplant. He presented with pain in the extremities, and this is the clue. This is the groin area and the lower part of the abdomen. Chronic kidney disease, pain in the extremities. What is this? Purplish in the groin. Yeah, so these are angiokeratomas, very fine thing. And CKD is because of Fabry's disease. This is Fabry disease. Probably this is the last. So this child presented with peripheral neuropathy, difficulty in walking, deformity of the lower limb, and there is a strange swelling in the bilateral ankles, and white matter changes, and cerebellum dentate nuclei also shows changes. What are these two strange swellings, and how do you connect this to brain?
Friedreich's ataxia.
Not the pes cavus. Look at this swelling here. So what is this? What is this part?
Tendo Achilles.
Yeah. So this is the cerebrum. This is the tendon. So what is this?
Cerebrotendinous.
Yes, it turned out to be a xanthoma. It is cerebrotendinous xanthomatosis. It is a kind of a treatable condition. Enodeoxycholic acid. I think that's it. Yeah, you can read about the enzyme replacement therapy. Yeah.
So, thank you, sir. Thanks for this beautiful vignettes, case vignettes and quiz. I think we all enjoyed that. I think we come to the end of the session. I'd like to thank all the PGs and all the moderators as well as chairpersons and all the office bearers. I'd like to hand over to Rajendran, sir.
Yeah, it's a wonderful case presentation by Dr. Sivan Kesavan under the guidance of Dr. Thangavel sir. And I really great to see our Professor Dr. G. Kumaresan sir. I think he's with us today. And I think I invite Dr. G. Kumaresan sir, your overall view, sir, please.
Thank you very much. It's a good, interesting case. As from the postgraduate days, extrapyramidal disorders has been a nightmare for me. It's a long list. It's a good thing that you brought it and you narrowed down to a few common conditions which a postgraduate should think. You have beautiful elaborators starting from Wilson's to PKD to mitochondrial disease. You have put the order beautifully. It's a difficult case, well, a difficult system, selected well and beautifully presented. I also learned a lot.
Thank you, sir. Thank you, sir. You're with us. And now I invite today's judges, Dr. Ramachandra Mohan, and please, sir, madam.
Special thanks to IAP TNSA to be sharing a platform with my GK sir, who has taught us neurology. We were all privileged to be his students. And neurodegenerative, as he said, it was compulsory long case for us. I don't think our present generation of postgraduates have that. But he taught us how to analyze, how to come to the diagnosis. And I still remember the mnemonic SOAP and MMC. And I should thank him and the present Dr. Ranjit and Shivan Keshavan. It was excellent. Something that, it was something was little higher than what a pediatrician needed to know. But I guess this kind of an approach only, we're not going to do it every time. So we learned a lot. Thank you so much. And the last 10 minutes of your slides, it was like a quiz and all of us were trying to get the answers right. So thank you so much for this very interesting session and very well mentored. I don't know, Dr. Shivan, whether your PGs have been tutored or what. They did an excellent job. All three of them were vying to give the right answers. On the whole, a very enjoyable session. Thank you, Rajendran, for all.
Thank you, madam. Thank you. Dr. Srinivasan, sir. Sir.
Yeah, very good presentation of a very good case, of course, and very well discussed by Pandits. And I'm very happy to see my Guru, Dr. Kumaresan, whom I have been asking him to write autobiography, so that he can motivate many more people to take up neurology. I have given him time also. I hope he is doing it and he'll soon publish it by the end of this year at least. Yeah. So, of course, Dr. Ranjit Kumar and Sivan Keshavan are ideal pediatric neurologists to be, there, and I'm happy that they are doing a wonderful job. And I have myself learned so much from them. Thank you so much.
Yeah, thank you, sir. Dr. Thangavel, sir, from Director Mehta, sir.
I am so happy that I learned both from my teachers as well as my students. Fantastic session, fantastic session. Lot of new things we learned, even though it was above our level of for a general pediatrician. But the teachers, Professor GK, Srinivasan sir, Shivan and Ranjit, they extremely taught us so many things. I'm very proud about our students, Dr. Safa, Gomati and Swati. They did extremely well. They were boldly confidently facing the senior teachers. Thank you, Rajendran, and for arranging this wonderful session. I'm privileged to listen to this. We learned a lot from both sides, from our teachers as well as from students. Thanks a lot. Thank you very much.
Only disappointment, I didn't see Kumaresan's face in video form.
Yeah, thank you, sir, and it's kind words. And I request Dr. Ranjit Kumar, we are concluding the note.
Sir, thank you very much. Thank you very much to the IAP and all the organizers. Thank you, Shivan, for inviting us. I must say, I do a lot of PG teachings like this. This group has been done really well. So they have been well trained. So almost they found out all the answers for the quiz. So thanks, Kumaresan sir. We could not see your face, and thanks to Srinivasan sir, he is a very great well-wisher of us. And thanks Rama madam for being the judge. And thanks Thangavelu sir. And it's a good opportunity for me to relearn pediatric neurology, because now I am doing fellowship and lost touch with core pediatric neurology for more than a year now. So it's a good opportunity. Thank you very much. We'll keep in touch.
Thank you, Dr. Ranjit, and Dr. Sivan.
Thank you, sir, for this opportunity. I'd like to congratulate all our PGs, Dr. Safa, Dr. Swati, and Gomati. They're very brave girls and very sincere, very interested. They did a very good job. So, good job, girls. You did
Thank you,
very well.
sir. Thank you for this opportunity.
They're all self-made and very hardworking students. I wish them the best. It was a pleasure sharing the stage with all teachers and senior pediatricians and pediatric neurologists. Thanks for the opportunity.
Yeah, on behalf of IAPTNSC, I thank Professor Dr. Kumarasan sir and Dr. Sivan Kesavan, Dr. Ranjit Kumar, and as well as Meta Director Dr. Thangavelu sir, and all the postgraduate. Actually, one of the best presentation by our postgraduates. I thank all the judges. That's Dr. Rama, as well as Dr. Srinivasan sir. And it's a great presentation. And now I request our Honorary Secretary Dr. Tirumurugan sir, and he is a background of all the program, and he is one of the person who is doing all the work. And really thank Dr. Tirumurugan, and I invite Dr. Tirumurugan to give a vote of thanks.
Thank you, sir. I think as everybody pointed out, this was one of the best presentations we have had for a very long time. Very difficult case, and as everybody said it, yeah, it was a very systematic approach, and it was an absolute joy to listen. And as senior person saying, a lot of things to recollect and a lot of things to learn. So I think I should thank Dr. Sivan Kesavan, Dr. Ranjit, and Professor Kumarasan sir for a wonderful discussion. And of course, my Professor Srinivasan sir for. I'm just envious of him. I just do not know how he remembers everything after, and he claims he is getting old actually. So thank you very much, sir. And thanks, Rama ma'am, and Dr. Academic Coordinator, Dr. Rajan. Such a impressive presentation wouldn't have been there, but for the PGs who really excelled. I'm just wondering, as Dr. Thangavelu sir has put in the WhatsApp, it looked like they were DMP students rather than pediatric PGs. So congrats to all three of them. And we are very happy to have you, each and every one of you all here. Thank you very much, and hope to see you in about 2 weeks' time. Thank you.
Thank you.